clear that even some of the first cases that were described there did not have any contact with the seafood market, telling you that this was a virus that was spreading in the community like other coronaviruses do. And it's important to remember that this is the 7th human coronavirus we've discovered. And 4 of those coronaviruses cause about 25% of our common cold. So that this virus is spreading in a manner that's very reminiscent of the common cold causing coronaviruses, and with a much more severe course. 2 of the other coronaviruses, and this is why coronaviruses were always considered very dangerous, was because of were SARS and MERS, which appeared in 2003 and 2012, respectively. These viruses have a very high mortality rate, 10% for SARS and 30% for Middle East respiratory syndrome, but don't spread efficiently between humans. So they were never considered major threats, although they were always deadly. And people really didn't develop vaccines or antivirals against them because they didn't really spread. And that's why we've kind of neglected coronaviruses for quite a long time, because it's 17 years after SARS and we don't have anything really for these coronaviruses. And what we saw was that this virus, even before it was noticed in China, had likely spread all over the country, because we're all over the country of China, as well as to other countries in the world. Because we know, for example, that sewage from Italy was positive in mid-December. We know that people got diagnosed in France around Christmas time in 2019. So this was already gone by the time it was even noticed, which is not surprising if you look at what type of a virus this is. A respiratory virus is something that is very hard to stop, especially when you have people with very mild symptoms who don't even know that they're sick, who are contagious. And that's been something that has never been containable. And I think when this virus appeared in the United States, the first documented cases were in January. It likely was here before that time as well, just was mixed in with our colds and flus at a very small number. And there was a lot of mistakes made early on, the way that we scaled up testing very badly, the way that we were only testing people from China when this was already in Europe, and just a lot of evasion that happened at the very high levels of the federal government that got us to a situation where in March or April, we couldn't do a Taiwan approach where they were able to test, track, and isolate and not have to shut their whole economy down. We basically squandered that time, and governors were left with very blunt tools, including stay-at-home orders. And they applied them very broadly, and they did a lot of damage to the economy. And that was because we didn't really have the proper infrastructure in January, February, and March, and let this virus spiral out of control. And now what's happening is the same thing is happening in states like Texas and in Florida and Arizona, where they had time to develop an infrastructure to be able to test, trace, and isolate, have contact tracers, and they again squandered that. So we're now seeing the United States being most likely the country that's dealt with this virus in the worst possible manner, even though we were ranked as the most prepared country for a pandemic. And I think this really underscores the need for pandemic preparedness and to do this better the next time. We will probably see this will be a threat for us no matter any activity that we do. This is going to be a threat because this virus has established itself in the human population now in the United States. So until we have a vaccine, every person is going to have to think, is this activity worth it? Is what I'm doing worth the risk? And I think that's something that we in the United States have not done for a long time, had an infectious disease threat that we have to think about every time we go out the door. And I think that's kind of going to be the new normal. And there are going to be people that get sick and that die from this. And it's something now that we're going to have to almost accept, because we've made so many bad mistakes early on in this pandemic. So that's kind of a little bit of the overview. And then I'm happy to whatever format you want to do for the remainder.
Sure. I have the list of questions that have been sent to me before the meeting, so I can read them to you right now. So you mentioned about the vaccine earlier, Dr. Aldaja. So what is the latest on the development of this vaccine? Is there light at the end of this long and dark tunnel? And what is the timeline?
So I do think that there is light at the end of this tunnel, but I don't know how long the tunnel is going to be. So you have to remember that vaccine development is something that is usually measured in years, not in months. But we are moving very rapidly. There's something called Operation Warp Speed that's being put into place in the United States, where some of the more promising candidates for vaccines are being manufactured ahead of time before we know whether they work. So this is something that will hopefully decrease the time to getting a vaccine. And we do have vaccines now in advanced stage clinical development, even phase 3 development, there's no biological barrier to having a coronavirus vaccine. I just think there hadn't been will to do it. And we do have coronavirus vaccines for cows and for birds. So this isn't something that we can't do. The veterinarians have done it for a long time. It's just the question is, can we get this vaccine manufactured at high enough of a scale to be able to vaccinate the entire country or the entire world? So I do think it's in the realm of possibility that by the end of 2020, the early 2021, we have some batches of vaccine, but not enough to put into the arms of every American or every person on the world. We may see some healthcare workers and high-risk individuals be vaccinated, but I do think it's probably looking at more of a scale of 2 years before we have the entire population vaccinated. So I do think we're going to be dealing with this threat for some time.
So it's looking like the best possible timeline is end of 2020 and 2021. We would have an initial vaccine.
Right, but it's unclear that we would have enough to, I mean, this is going to be very small batches, and that's if everything goes perfectly and there is no errors while you're scaling up production.
Mm-hmm. And so, okay, how about the cure? Have we found the cure or treatment to this? What is the best or most effective so far? And how accessible or available are these treatments?
So we don't have a cure. We have some treatments that may help. So one right now is called remdesivir, which has gotten an emergency use authorization from the FDA. It is an antiviral drug that was originally developed for Ebola and then repurposed for the coronavirus. This seems to at least decrease the amount of time someone is in the hospital. So if you get out of the hospital faster, you get better quicker. But it doesn't appear to have a difference in mortality if you get it, although there is some data that shows maybe that's the case, but it hasn't really been published properly to be able to say. One other thing that we do give people is if they need oxygen, we can also give them steroids. And steroids have been shown in one trial to decrease mortality, maybe by about a third. So we do have some treatments that in July that we're using that we weren't using in March. So hopefully that will bring down the mortality rate of those individuals who get hospitalized.
Mm-hmm. And so, so right now, remdesivir is sort of like the best under the circumstances.
I actually think steroids are better than steroids. Actually, have more data. There's a steroid called dexamethasone that I think has better data than remdesivir because that showed a mortality benefit. Remdesivir just showed that it could get people out of the hospital faster.
Oh, okay. There's a follow-up question to that. What is the treatment for someone who tested positive but is asymptomatic? Is a 14-day quarantine enough to declare him or her safe?
There is no specific treatment for an asymptomatic individual, and it's actually not a 14-day quarantine. For somebody who is tested positive, the quarantine is 10 days, with 3 of those days, the last 3 days being without fever, not using a drug like Tylenol or ibuprofen. So it can be as short as 10 days if you're positive. When we're talking about an infected person, we don't use the word quarantine, we use the word isolation as well. So it's 10 days of isolation if you're positive, and no specific treatment for somebody who is asymptomatic.
I see. And then so after the 10 days, if you test negative, then you
don't even need to do a second test. No, you don't have to do a second test, just a time period.
So if you're asymptomatic, if you stay asymptomatic up to until 10 days, you're okay. In isolation, rather. You're
yes, in isolation for 10 days, yes.
Okay. Our next question is, we have been experiencing an upsurge in infected cases and deaths. And this came from California. Are we experiencing a second wave now, or is this still a bump in the first wave? Should we expect a second wave? And will it be worse? That was the question.
So I think it's still the first wave. We never had really gotten control. Even during the height of our stay-at-home orders, we were still having 20,000 cases a day in the United States. So this wasn't something that we ever had. We never got out of the first wave, and we may not see. Waves have troughs and peaks. I don't think we'll see a trough. So I don't really get into the business of trying to number the waves, but this is still our first bout with the virus. I do think that in the fall we have to think about this intensifying because, for example, we may have schools open, we may have a weather that is more conducive to spread, because we know that other coronaviruses do have a lot of seasonality where they intensify their spread and transmissibility in the fall. This one we may not get a break before the fall. I don't necessarily know that it will be worse, other than it might be able to infect more people. I don't think the virus will change to be more deadly, but I think it may it may have a chance to infect more people in the fall. And we have to prepare for that, because at the same time that the fall comes, influenza will also be circulating, and we know that they're going to be competing for the same resources in hospitals, because the same mechanical ventilators, the same personal protective equipment and oxygen, and in the same beds are all good. So it's really important that we get very high levels of flu vaccination this season, before we get into the second fall wave, so that we have enough beds open for coronavirus patients that are not, and we don't have them all occupied by influenza patients.
And so you're saying then that in fall we might expect a second wave, or will that still be a surge from the first one?
Well, I don't see, when you think about a wave that seems to be discrete, comes
Yeah.
up, comes down. I don't think we just came up and we just may keep going, like that. It may not necessarily look as sharp. It's like when you see influenza, it goes up and it comes down like that. It has a seasonality. I don't know that we'll see that, because we've got so many people infected right now that we don't see we're not getting a break in the summer. And I think so I don't know if you can call that a wave, or it's just continually like a forest fire, just burning.
Wow. And so are we, and this is my question, are we in a better position now than we were, let's say, in March when our lockdowns started? Or if we do experience an uptick or another wave, are we in a better position to meet that, to respond to that wave?
Yeah. I do think we're better in July than we are in March, because we know a lot more about the virus. We know the risk factors for severe disease. We know what the complications are, at least some of them, and know how to prevent them and predict those complications. We have remdesivir, we have dexamethasone. We understand how to treat people better with mechanical ventilators. We have more personal protective equipment, more mechanical ventilators. We've gotten much better at understanding that we have to be very aggressive with nursing homes. Over 40% of the deaths in the United States were in nursing homes, and we had bad mistakes made early on, where you had governors, for example, in New York and Pennsylvania, forcing nursing homes to take COVID patients, and then that virus basically spread like wildfire in some nursing homes and killed a lot of people. So we're much better in terms of that now in July than we were in March.
That's something positive. Anyway, so we have a question from Dr. Cabrera, who is a professor in the Department of Biology in De La Salle University in the Philippines. And she says, considering the instability of the genome of SARS-CoV-2, which results in the emergence of new strains, how will this impact on the vaccine being developed as far as coverage is concerned?
So a couple of things. So coronavirus in general have pretty strong genomic stability. They have a proofreading mechanism. So when they make errors, they can actually correct them. So of respiratory viruses compared to like influenza, for example, coronavirus tends to be much more genetically stable. And when you look at the vaccines that have been developed for cows or for birds, those have been effective over time. So we haven't seen them escape away from the virus. And when we see that it's important to remember all viruses mutate, and the mutations that we've seen with this virus have not been such that they're changing their immunogenicity or how the immune system sees them. So I don't think that this will be a problem for coronaviruses the way it is for influenza. Obviously, we have to watch this and check and make sure, but my initial analysis is I don't think that this will be a major challenge for the vaccine manufacturers as of now.
And I think this is a follow-up question. What's the latest on neutralizing activity of the antibodies elicited in the patients? Is administration of plasma from previously infected patients effective in the treatment of the COVID?
So we are seeing people that get infected do develop antibodies that are neutralizing in nature, meaning that they can stop the virus. And there are current trials going on for convalescent plasma. We've seen mixed results, nothing definitive yet. A lot of people have hope in convalescent plasma, but I don't think we have definitive evidence to say whether it works yet. But there's a lot of promise with convalescent plasma, and I do think that the idea of these neutralizing antibodies are going to be used to make what are called monoclonal antibodies or synthetic antibodies that can be administered as drugs. And there are companies like Eli Lilly and Regeneron that are making monoclonal antibodies that could be used as a treatment for people that are in the hospital.
Mm-hmm. And related to that, there was some breaking news. I think that was yesterday that a new mutation in the protein called, I think, this 614G that
Yes.
allows the SARS to enter cells and might make it easier for the virus to spread. Will this make a difference at all? How does this affect
So
the?
this mutation, the D614G, seems to be everywhere in the world except for Santa Clara County in California and Iceland. This mutation, at least in the lab, it seems to be more effective at spreading, but we haven't been able to correlate that with what's going on in humans yet. So I think it's important to remember that there's still a lot of questions about this mutation. It doesn't change the severity of the disease or anything. It just appears in a laboratory setting to be have an easier time spreading. So I think this is something we have to watch. We don't know exactly what its implication means. And it has no change and it has no difference in its severity if you get infected with this strain or another.
And so, and you mentioned that Santa Clara County does not have that, and which other places?
Iceland.
Iceland, I see. Wow. And I wonder why. Okay, so this question I think came from a senior. So what? Let's talk about our senior or older population. What makes them extra vulnerable?
So as you get older, you're more likely to have other medical conditions. And for example, cardiovascular disease, which is very common. You're more likely to have diabetes. You're more likely to have other conditions that affect your lungs, for example, like emphysema. And you've had them for a longer period of time, so they've caused more damage to your body. So in the end, you have less what we call physiological reserve. So, and this is common with not just this coronavirus, but any respiratory infection. We see it with influenza every year. We see it with even adults who get RSV or other respiratory infections have much more severe courses. So this is not something that's surprising. And we also know that the immune system of an elderly person reacts differently than that of a younger person. So there's many different factors, but it's not surprising to me that as you age, your risk for severe disease increases with this coronavirus.
Thank you. And we've heard a lot about this word, herd immunity. What is this, and how do we get this, or how do we get there?
So herd immunity is a concept of a population having enough people that are protected against the virus, that the virus, or whatever, it could be a bacteria, whatever it might be, it cannot spread. And it's a function of how contagious the virus is. So for a virus like measles, you have to have 90% of the population immune to keep it from spreading. And that's why we're so aggressive with measles vaccination. For a virus like this, you may need to have maybe 60% or so immunity in the population based on its contagiousness. So that's basically the level, it's the level of immunity necessary to keep an infectious disease quiet in your population. And we will probably get there, but most likely through a vaccine, because even in places like Sweden, which explicitly pursued a herd immunity strategy, basically letting the virus infect people at will, they didn't really get that high. There are some spots in New York City where they've seen pretty high rates of immunity, but overall in the country, only less than 5% of the population has been infected. So we're nowhere near that herd immunity. So I suspect when we get to herd immunity, it will be through a vaccine, not through natural infection. Because if you try to let that virus infect everybody, you're going to get deaths at a very high rate like they did in Sweden.
Mm-hmm. So it's not something to aspire for.
No, it's not something to aspire for.
Okay. And a lot of debate and discussions are also occurring around airflow. How does, the airflow, what's that, this, transmission, airborne transmission, how does that hasten or affect the spread of the virus?
So this is something that's controversial and is sort of a dispute between doctors and aerobiologists, and I don't think it's very complicated and hard to understand. We know that this virus is likely spreading between people that are in close contact, less than 6 feet for 10 to 15 minutes, usually through large droplets that fall to the ground by the force of gravity. When you talk, when you do things, you do get some aerosolization, but is that aerosolization responsible for infection? It's hard to say, and I don't think it's actually been that much of an issue because many countries that have controlled this controlled it as if it was a droplet spread infection, not an airborne infection. Measles, which I mentioned earlier, is the classic airborne infection, where if somebody has measles is in an elevator and you go in the elevator 20 minutes later, you can be infected. We're not seeing that epidemiology here. We're not seeing it, people and healthcare workers getting infected as if this is an airborne disease. So this is kind of becoming a major dispute in the field. So I do not believe that we have to change anything we're doing based on this small amount of airborne that may or may not be there. And if you read the WHO's guidance, they talk about the fact that this has not been definitively proved and they can't rule out those cases where it's happened, that maybe it was droplet or maybe somebody touched common touch surfaces that were there in the study. So I haven't changed anything based on this finding. And I think it's something that is going to be in the news for a while, but I don't know that it's going to make a major difference, although it's going to create a lot of headlines.
Mm-hmm. So, but for now, there's very little transmission through that from the data that we have.
Yeah, it's not definitive, and we know, so airborne transmission can occur when you're in the hospital and you're getting a bronchoscopy or getting intubated or getting a drug aerosol treatment or being put on a CPAP or a BiPAP machine. That's clear, but does it happen in ordinary life? Even though you might be able to find the particles in the air, are they infecting people? Is it a major route of transmission? I don't think that's been proven.
Mm-hmm. And so how about the factor of time, Dr. Aldaja? Does time of exposure factor into the probability of infection?
Definitely. The longer, so even to be considered a close contact by a CDC contact investigator, you had to have been at least 10 to 15 minutes with that person. So this does not spread in fleeting contact when you pass somebody on the sidewalk.
I see. So, probably in relation to that, if there's a question here, if and when you recover from COVID, are there long-term or residual effects on the body afterwards? Is it true that your body is weaker and breathing will be more difficult after recovery?
So it is true for any infectious disease. If you end up in the hospital, if you end up in the ICU on a mechanical ventilator, you're going to have a prolonged recovery and you're going to have diminished lung function, which may not come back to normal. It may take you some time to be able to walk up the stairs as fast as you could or exercise. And that's not the case just with this coronavirus, but it's with any kind of infection that lands you in the ICU and makes you critically ill. We have this whole thing called post-ICU syndrome, which you can look up. That definitely happens. With this coronavirus, there is some things that are unique. For example, loss of taste and smell, that can last for some period of time. We also know that some individuals rarely can get strokes or blood clots in their lung. Those are going to have a long recovery time. Mild cases usually get better in about 2 weeks or so. They're back to their baseline. Although there is a subset of people who do have kind of chronic fatigue after this. And we don't quite understand this. And this happens with many other viral infections as well, that there is some subset of the population that after they had an acute infection have prolonged symptoms that take some time to dissipate. And we don't see anything abnormal on their labs. It's probably a genetic predisposition that we don't understand yet, but that does happen, but it's not the norm.
Okay, so it does. So it actually depends on individual cases and probably the age when you got it, right?
Yes, and what other problems you have and other medical conditions. Yes, yeah.
So if you do get the virus, how long does it stay in your antibodies? Are you then, if you get the virus and you recover, are you then immune for life? Or
this is a question we don't know the answer completely to yet because we haven't had this virus around that long to follow these people. We've only had the virus really since November or December. So we haven't seen these patients, we haven't done what's called a natural history study where we follow these people out for a long period of time. But we know in general, when you get an infectious disease, you're usually not able to be reinfected for a period of a time, maybe at least a year, if you can base it on other coronaviruses. So we don't know, we don't have all the data yet, but I think it's a fairly solid assumption to believe that we are protected from reinfection for a period of probably a year or so in most cases.
How about children and young people? Are they really spared from the virus as we were led to believe?
For the most part, children definitely are really they're not really people who get symptoms. They're not people who end up in the hospital. There is this inflammatory syndrome that rarely can occur in children, but it is not the norm. Most children don't have any symptoms at all, and they actually aren't major spreaders of this virus. Unlike with influenza, where they magnify influenza in a community, they don't do this with the coronavirus. So this is one of the reasons why there's a big push from the American Academy of Pediatrics to try and open schools, because of this epidemiology that we're seeing with children. The same is true for younger people in general. They are not ones getting hospitalized, so that's why you see a lot of cases all over the country, and not every place has big hospitalization rates. So here I'm sitting in Pennsylvania and Pittsburgh, we have a lot more cases every day, but they're all happening in younger individuals who do not necessarily need to be hospitalized with this.
And most of the time they probably have it and don't know it, that they're spreading it maybe.
Right, so that's kind of, yeah, that's an evolutionary advantage this virus has, that the young people don't know they have it but are contagious.
And are not, and mostly probably asymptomatic, most, right? So at this point, I think that's about the major questions that we got. If there are any other questions from our attendees right now, right here, please feel free to ask, or write them down in the chat function for me to say. Dr. Cabrera, any other follow-up question?
Sorry.
Say that.
I think there's a question in the chat box about the vitamin C and D. There's a question there in the
okay,
chat box.
So does vitamins such as vitamin C or D help in immunizing a person?
So I think for most people, they have enough vitamin C in their daily diet that I wouldn't supplement. Vitamin D is a little bit different. There is probably some data that vitamin D may be helpful, and there are so many people that are vitamin D deficient that it probably is something that people should be, make sure that they're getting enough vitamin D. I wouldn't supplement for treatment other than the people that are deficient, but many people are deficient with vitamin D, and I do think that there probably is some data that will emerge that vitamin D is important in the symptoms that you have from this.
So there's another question from here in California. If a person that is on CPAP machine gets COVID-19, what additional challenges are there in their treatments?
Well, it depends on why they're on CPAP. If they're on CPAP for just sleep apnea, it's not that big of a deal, other than the fact that you have to be careful about using the CPAP in your house if you've got other people sleeping in the same room as you, because you will aerosolize the virus with CPAP. So you should use it by yourself. If you're on CPAP because you have emphysema, obviously you've got a lung disease there that's going to put you at higher risk for complications.
Mm-hmm. And we have another question on the chat. I think this comes from the Philippines. How do you interpret the result from our rapid COVID tests here in the Philippines? IgM-AB negative, IgG-AB positive. So I think they were looking for how to interpret.
So that, in general, that would mean that someone has had prior exposure to the virus. And it happened some period of time ago, because the IgM antibody is the first to come up. And if it's negative, that means that that person has already gone through the acute phase, and now they just have the chronic antibody there. So that's probably an infection that would be consistent with an infection several weeks ago.
So that means they had the infection but are over it, or?
Yes.
Okay. And if it's IgG-AB positive, then they have it, they're infected.
No, IgM would be an acute infection. Okay. IgG is the chronic antibody. The IgM, if you had the IgM positive, you would probably still be in the acute infection stage, or just coming out of it.
Okay. And from Dr. Cabrera, is an anti-inflammatory agent part of the routine management of critical patients?
Yes, it is. We are using dexamethasone, which is a corticosteroid, and the steroids work as anti-inflammatory agents. We do use other anti-inflammatory agents for severely ill patients, like IL-6 and IL-1 blockers, like anakinra or Acmera. Those are being used as well.
Mm-hmm. There's a lot of talk going around social media also that drinking large amounts of hot tea with ginger and lemon helps increase immunity to the virus. How true or how effective is that?
I don't suspect that has any effect.
Okay. All right. It's time check. It's 5:30, and I know that you agreed to be with us only for half an hour. at this point, any final comments or final advice to all of us?
I think this is going to be a challenging time. This is something that is now established in the human population, and no activity is going to be without risk. So you're going to have to think, what are my values? What's important for me to do? And how important is it for me to do it? And is it worth the risk? And you just have to realize that any activity you do, the virus is going to be with you. So you need to act responsibly because we're in a pandemic. So there are simple comments. That doesn't mean you have to lock yourself up in your house. That means that you just have to be careful and mindful. Wear a face covering. If you don't like to wear a mask, wear a face shield. Try to avoid places that are really crowded. Don't go out if you feel sick, even if you feel mildly sick and you think it might be because you slept wrong. That's what's happening is people are going out with mild illness and spreading it. And just really be careful because the virus is going to be there, especially if you have high risk conditions. So thank you again for.
Thank you. On behalf of PCAA and our attendees, we'd like to thank you, Dr. Aldaja, for your time and your valuable insights and advice. Thank you, everyone.
All right. Bye. Thank you.
Bye.